Hello, everybody, and welcome to our CAP webinar. Our topic today is on disruptive behavior and basic behavior management. My name is Joan Jeung. I'm a general pediatrician and the Senior Associate Director for the Child and Adolescent Psychiatry Portal, where I help to direct CAP CME programs. With me today, we have two guest speakers. Lauren Haack is a clinical psychologist and associate clinical professor in the UCSF Department of Psychiatry, and she provides behavioral and cognitive behavioral therapy in the UCSF Mood and Anxiety Clinic, as well as a hyperactivity, attention, and learning problems clinic. Her research interests include provision of accessible, culturally appropriate, and technologically enhanced services for children and families, as well as cultural influences in mental health assessment and treatment. Dr. Haack also works with the CAP portal, providing Reach Out and Connect, formerly Second Step psychological consultations for caregivers, and she's a frequent speaker for our CAP programs. Neal Rojas is an associate professor of pediatrics in UCSF's Division of Developmental Medicine. He's a developmental behavioral pediatrician who's been in clinical practice for over 20 years. He is a much-loved clinician within the division, as well as a medical educator whose research focuses on patient-centered care and medical education. As I said, we'll be speaking today on disruptive behavior and basic behavior management. We will be reserving the last 10 minutes or so for questions. So if questions come up, please feel free to type them into the question and answer section of the chat. And with that, let's go ahead and get started. We have no relevant disclosures today, and there's a little acknowledgement of some of our major funders. Next slide, please. These are our objectives. We want to be able to recognize disruptive and problematic behaviors in children, understanding when this is just normal and when this is a diagnosable disorder. We want to get some clinical pearls on how to guide parents with some basic parenting guidance, as well as resources. When things are outside our ability to be able to directly help parents, what are evidence-based psychosocial treatments for disruptive behavior disorders? And we'll be talking briefly on medications that may be helpful in the management of disruptive behaviors, including some tips on when they should be used. Next slide, please. So what exactly do we mean by disruptive behavior? And there is a wide continuum on what we mean by this. And it can range from everything from very normal behavior, especially certain developmental stages like the toddler years, or maybe during adolescence as well. And then we get into very severe disruptive behavior that's maladaptive and even violating of societal norms and the rights of others. So in distinguishing where you are on this continuum and what's normal or abnormal, it's helpful to think, what is developmentally appropriate for the age and stage of this child? How frequent is this behavior happening? What is the severity of it? Is this happening in one setting or in many? And sometimes behavioral rating scales can help us to make the distinction as to whether to be worried or not, and what level of support this child or family might need. Next slide. So when you are convinced, because of the severity or the pervasiveness or the frequency of the behavior, that this actually might be a disruptive behavior disorder, these are some of the actual diagnoses that we should be considering. Some of the more common ones that are listed in our DSM. So probably the most commonly encountered one in clinical practice is oppositional defiant disorder, or ODD. And you can see the definition here, where this is chronic behavior that's happening for over 6 months, and it's a consistent pattern of angry or irritable behavior, argumentative or defiant behavior, or even vindictive behavior that might qualify a child for a diagnosis of ODD. On the even greater severity end is conduct disorder, where it's, again, a consistent pattern of behavior that violates the rights of others and important societal norms. This, again, is chronic, happening over a year. Intermittent explosive disorder is a somewhat newer and lesser known condition where you have recurrent severe behavioral outbursts accompanied by aggression, either physical aggression or severe verbal aggression, often with property damage or physical assault. And this is happening with some frequency over the course of a year as well. There's also the other or unspecified category where this is severe enough to be a disorder. It has features of any or all of the above, but not quite fitting neatly into any of those buckets. But you want to be able to label this as a disruptive behavior disorder. And finally, this other diagnosis that's listed here, DMDD, or disruptive mood dysregulation disorder. It's not technically categorized in the DSM under disruptive behavior. It's categorized under the mood disorder category, but it shows up with a lot of disruptive behavior with extreme irritability, anger, and punctuated by these frequent, intense temper outbursts. So the distinction between this and intermittent explosive disorder is that for disruptive mood dysregulation disorder, there is just chronic irritability just running in the background all the time with these bursts of behavioral outbursts, basically. So those are some of the diagnoses that we should know about, but these very frequently come with company. Frequent comorbidities include ADHD, some other mood disorders such as major depression or bipolar disorder. Anxiety disorders can show up with disruptive behaviors, and PTSD and trauma can also show up with disruptive behaviors. We need a careful history. Otherwise, we run the danger of missing a diagnosis or just missing the boat altogether. Next slide, please. So when we encounter disruptive behaviors in practice, and again, we're thinking along the order of a disorder and not just a developmentally appropriate stage, our number one consideration should be a safety check. Is this child safe? Are others around this child safe? We need to think about child maltreatment. We need to think about substance abuse, either in the child or in the caregiver or in the family system. We need to think, is this child in danger or posing a danger to others? Some screening tools that can be helpful in figuring out what may be going on, like once you've figured out the child is safe. For younger children, there's a nice tool called the Survey for Wellbeing in Young Children. It's actually a developmental screening tool that also includes behavioral questions, as well as family stress questions and some trauma questions as well. Very helpful to have it all in one place. For school-age children, the Vanderbilts have specific questions asking about disruptive behavior disorders like ODD and cognitive disorder. The PSC-17 is a nice general brief screener that can help point you in the right direction, either for disruptive behaviors or for comorbidities. But an important thought here is, again, the age and the developmental stage of the child, because especially for younger kids, disruptive behaviors can be hard to categorize because it's hard to tell how this behavior will evolve. Is this just a challenging temperament? Are there particular parent-child dynamics at play, especially with a challenging temperament? Is there a trauma history that we should know about? Do we have an emerging neurodevelopmental disorder, such as autism spectrum disorder or global developmental delay? It can be hard to figure out until time helps to figure it out, and screening tools may sometimes be of help here. Next slide, please. Neal, I believe.
Great. Sorry, I was on mute. So we're going to transition now to how do we engage parents, regardless of whether or not you have a diagnosis that's been firmly established. If it's pretty obvious that there's challenging behaviors going on, the most effective way to help that child is through the parents. And often we will have parents who are resistant. And it can be for a multitude of reasons. Can be that they've tried already and they're very tired and they're burnt out. We might label this parent the oppositional defiant parent. They may have some of the same characteristics as the child, but at the end of the day, to be compassionate clinicians, we have to realize that them feeling blamed isn't going to help. Them blaming the child isn't going to help, and magnifying any stigma associated with the behaviors isn't going to help. And so if you hear them say, oh, this isn't going to be worth my time, or I tried that already, the feelers should be going up. All right, maybe we're a little burnt out. I'm going to need to help this parent feel listened to, and help them figure out how to fill their cup back up so they can then be open to parent level interventions, actual skill building in the parent to get different outcomes with the child and of course the parent-child interaction. Um, in terms of how much time and effort it's going to take to do this for that family member and however they're plugged into the system and getting support, I like to remind them that these problems didn't happen overnight. They're not going to be solved overnight. Oftentimes these challenges have been building up for months to years, but the work we do now in establishing you know effective techniques will pay off later. And the reality is, if we don't pay now, if we don't invest our time and energy now in helping the child, it's going to get harder and harder. So pay now or pay later. Next slide, please. So that brings me to specific ways of helping them understand. Oops, you asking me to speak louder? Okay, can you hear me better now, everyone? Yes? Hope so. I'll speak up. Great. Specific ways to help a parent understand whether or not what they're doing for the behavior is effective and what's actually going on. I like this model, the ABCs. It stands for antecedent behavior consequence. The process of using the ABCs is another three-letter acronym, functional behavioral analysis, which comes from the psychology community working with kids in schools. But another way to think about this, what's more simplistic, is the before and after model. What happened before the behavior and what happened after the behavior? And what did we learn as a parent or as a child or as a unit from that behavior? So here's an example. Mom says no to buying a new toy at the store. And the child screams and throws a fit in the store. This never happens, right? It happens all the time. And then the mom tries to calm the child down and promises to buy the toy. And so what has the child learned? Oh, when I scream and shout in the store, I get the toy. What's the mom learned? Well, it's going to calm him down really quickly if I buy him the toy. And so we've kind of negatively reinforced this behavior, and it's going to continue. And so thinking about the behavior itself, the screaming, where's that coming from? Is it coming from frustration? Is it that child's only means of communicating, or is there another way they can communicate? Do they have a specific goal in mind? Is it to get this specific toy? Is it just attention? I need something. What else could be going on there? We'll dive in a little deeper. Next slide. So I try to help families think about these scenarios in terms of, well, before you even go in the store, what do you do to help your child be ready for something that could be anticipated as a problem? Okay, because the ultimate goal here is to help them learn how to self-regulate, right? And so what could we do to modify the factors here in terms of helping that child? Next, click here. We have a whole list of things we can try, a whole bunch of strategies. We can help that child better name their thoughts and feelings. Like, do you feel like you need something? Do you feel like something's missing? Okay. We could be really clear with simple instructions and expectations for that child before we even go into the store. Of course, staying calm as a parent, not getting excited will help. Increasing the structure of what always happens when we go out with that child and what the expectations are. We always review what we're going to do in the car before we get out of the car. Having a backup plan, knowing that that the parent knows I have a way to calm my child other than buying them the toy necessarily in this scenario. And the child knows that can be reassuring as well. And so for this example specifically, I always ask, the before question in terms of modifying the environment, do we even need to go to the store, right? If this is a predictable problem in which this child's overwhelmed and it's creating a bad cycle of learned behaviors, maybe we need to table it for a while and work on some easier things before we road test this in the store. Or is it just enough to give the child some heads up information and they'll be able to handle it if they know what to expect? Maybe if the child actually has something in their hands to do to keep them busy, or a job to self-regulate, they won't be as stuck or fixated on getting the toy. So that's another way you can modify the behavior, kind of moving into the environment. And most importantly, and we'll get into this in terms of reinforcement, every few moments while that child is doing something within the realm of expectation, giving them positive feedback. I like how hard you're working here. You're helping mommy do this. Thank you so much for listening. We're going to go over to this section now. That's the kind of stuff that will sustain good behavior. Next slide, please. Okay, so kind of putting this all together, the after piece is the response to the behavior. How do we reinforce it? I was already kind of leading into that a little bit. Some tried and true methods that we'll get into much more detail later to increase positive behaviors is praise, praise, praise. Okay, we talk a lot about the 5-to-1 ratio of positives versus correctives, and Dr. Haack will get into that some more. Paying attention to the desired behaviors. If the child feels like they're getting attention, not just praise, but attention when they're in their lane and doing what's expected, they're likely to stay there. Providing incentives or tokens of appreciation in the moment. For the younger children, they need that distance between I'm doing it and I'm getting it to be really short. If it's I got to wait a week before I get the toy, that's going to be way too long. And then to decrease behaviors that are problematic, we're going to talk about planned ignoring, timeout, and losing privileges as those become sort of developmentally more appropriate as children get older. The bottom line here is the more attention you give the behavior, I try to teach parents, the more behavior you're going to get, more of that you're going to get. You want to catch them doing good. I'll try to stay in one place so you can hear my voice. I'm sorry, I don't know what's wrong with my mic. Catch them being good. Water the, feed the desired behaviors. Next slide, please. Next slide, please. Okay, great. So this leads to the concept of parent behavior management training and then family-based treatments. The better you know about these types of programs that exist in your community, the better you can help children and families. The rationale is that children with behavior difficulties, they experience more stress, conflict, and chaos, and parents affect that too.
So as Dr. Rojas was explaining, we know the most about working with parents and teachers in the child's environment. That's what we have the most evidence for. These parents in particular, research shows us that they feel more stressed and also less efficacious. They feel less confident in their ability to effectively parent, which in turn actually influences indeed their ability to parent effectively. So across the different brands of these family-based and parent-based treatments, there are really some consistent trends, which we can break down into the 3 C's. So we're going to talk about strategies that really focus on increasing the consistency in the expectations and the messaging that we send our children with DVDs, also the clarity of these expectations and celebration. So as Dr. Rojas mentioned, we're really focusing on much more positive reinforcement for what we do want our child to do, or even steps in the right direction, with less emphasis on correction. Other kind of things that these treatments tend to focus on or tend to include are psychoeducation about what are disruptive behavior disorders, what cause them or contribute to them, and the associated features. This really kind of sets the tone for why we're working so closely with parents and families. And it really focuses on improving this negative parent-youth interaction cycle that develops, and we're actually going to look through an example of that in the next slide. We are going to across the treatments as well, really talk to parents about clear expectations and consequences. And as the child actually gets older, we include them more and more so that parents and youth work together on strategies like problem solving and effective communication. So again, across a lot of these different treatments, the 4-factor models of family interactions are targeted. So let's take a look at a really common example of a negative parent-child interaction. So let's say a parent tells their child a command or an instruction, put your backpack away. Now, let's say the child doesn't do this. If we advance on the slide, I'd love some audience participation here. What might parents do next? We gave them an instruction, they didn't do it. So I'd love answers in the chat. What might happen next? What might a parent do next? Say it again and louder. Absolutely, right? So if we advance to next, they'll probably repeat it, but not in the same way. They'll probably be louder, maybe even angrier, right? Put your backpack away. Now, one of two things could happen. The child could comply. And if that's the case, what did the parent learn? The parent learned that they have to raise their voice in order for their child to comply. So they're probably going to start there next time. They're just going to go straight to saying the command loudly and perhaps angry. What did the child learn? Well, the child learned, I don't really have to do it until my mom or dad raises their voice, right? So you can see how their interactions are automatically going to be more escalated moving forward. But if we advance, let's say the child still doesn't comply at this point. What might the parent do next? They've given the command, they've given it again and louder. What might the parent do next? Please feel free to put in the Q&A some thoughts. Great. Make a threat or give a consequence, right? So at this point, let's say the threat works. Now they've learned, okay, well, I have to make threats in order for my child to do something. And the child's learned, I don't really have to do it until my parent makes a threat. Now, let's say they go with Dr. Wong's example and the parent just gives up and does it for it. If we advance, Jessica, we'll see. Okay, great. Now what does the parent learn? Well, really, I just have to do things for my child. I can't expect these things from them at all. And the child's learned, if I just hold out and wait long enough, I don't actually have to do these things that my parent's asking. So by the time your families are walking into your office complaining about DVDs, this pattern has likely been entrenched and happening for a long time across a variety of behaviors. And so all of these treatments really focus on turning this interaction on its head into a more positive and effective interaction. And we're going to look at what are strategies along those 3 C's that help us do that. So if we go to the next slide, one of the first kind of buckets of strategies are really focused on clarity. So we talk to parents about how to give really effective instructions that are reasonable, something that the child can actually achieve. And also we really want to focus on saying what the child should do rather than what they shouldn't do and being really specific and clear. Right? We're not actually very good at this as adults. We usually will say vague things like, oh, be careful, behave, be good at grandmas, right? Or we'll say what we don't want them to do. Well, don't run, don't yell. And that doesn't actually tell the child what it is that you're expecting of them, right? So the more clear we can be, the more we're setting our children up for success to follow our directions. Another thing that's really helpful is making these expectations be as routine as possible and creating a visual reminder of this, right? So have a morning routine, for example, because mornings are really hard for a lot of families, but particularly families of kids with DVDs, outlining what are very clear steps that you need to do in the same order at the same time in the same place every day. And we're going to post this actually in every single room that you have to do these steps so that it starts to become habit and second nature, right? And it's really important that we're pairing all of these steps, following a direction, doing a step of the routine with praise and also rewards. Right? And these don't have to be big, expensive, fancy rewards, right? Like I've had parents ask me, will you expect me to buy my kid a toy every time they hang their coat up? No, really what we're talking about are privileges that the child's probably already earning for free that now you're going to set up as something that they can earn for doing their routine, right? Other nice rewards are choices, right? Maybe they have a choice of their favorite seat at the dinner table or listening to the music in the car on the way to school after they've done their morning routine. Right. So on the right here, you can see these are some examples. Someone asked in the Q&A before about resources to remind parents or kind of teach parents of some of these strategies if they're not able to access parent management training, if they're on the wait list for one of those programs, or if unfortunately it might not be realistic for them to have access to those. And so all of these links that we have, they usually have short videos, sometimes handouts as well, and most all of them are available in English and Spanish. We'll also have a slide at the very end with a QR code where you can actually download a handout and just give these out to parents. If we go to the next slide, we'll see that the next bucket of strategies really focuses on praise and rewards. So as Dr. Rojas said, we really want to strive for 5 positive statements to every 1 correction. And this is really helpful for any human being, but really critical in children with DBDs, because what we know about the brain pathways in these children is that they actually over-perceive positive feedback and under-perceive negative feedback. So we have to actually be very deliberate about how often we're doing that praise and how specific and clear it is so that they're really learning how to do these things that we want them to do. I kind of gave away the punchline here before about what effective rewards are, and really we're focusing on things like privileges and choices. What's super important is making sure that the child's included in this so that the rewards are actually something they're motivated by. And this is probably going to change over time, right? So sometimes what we as adults think is really motivating, actually the child couldn't care less about. And sometimes the kids have really creative ideas that we would never think of. So including them and keeping it, switching it up can be really helpful. If we go to the next slide, especially as the child gets older into preteen and teen years, we're going to include them more and focus on how they're communicating with people in their environment. And we really want this to be frequent and open with parents. And we want parents to strive for this balance of giving the teen enough independence so that they can feel autonomous and confident, but also giving them enough support so that they're able to succeed. Some really helpful strategies is trying to help the parent put themselves in their child's shoes, right? Whatever is happening in that child's world makes sense to them. Most behaviors, almost all behaviors, are happening for a reason. Even if we don't agree with that behavior or long-term it's not effective, it's probably happening because it's effective in some way in the short term, right? So if the parent can reflect that and empathize and validate that they understand that this is happening, that the situation sounds really hard, and they're going to help them through thinking what could be a more effective strategy, that's going to be much more effective than just demanding without getting any of the child's input. If we go to the next slide, another part of being consistent as a parent is making sure that we have our stress and our emotions regulated and under control. And this is no easy task for anyone, let alone the parent of a child with a DBD, right? So we want to talk about helpful thinking strategies for why their child's misbehavior is happening. So for example, if I think my child got called to the principal's office because they're out of control and they're super disrespectful and they're never going to be able to follow rules, they're never going to be able to be successful and have friends and have a job, I'm going to react very differently than if I think, you know what, my child had a hard day today, you know, it's been a really busy week at home and I can understand why maybe they were struggling. We can really think through this and have him set up for a better day tomorrow, right? You're going to have much more effective parenting in that second frame of mind. It's also important to do the age-old adages of putting our oxygen masks on ourselves, right? We cannot pour from an empty cup. And as trite as those sayings are, they are absolutely true. So how can the parent even do tiny things for their self-care and stress management, right? And this doesn't have to be going to the spa or something super long and fancy. This can be even just making really small tweaks in the day so that the parent's able to get a little bit of self-care. And some of these videos we have here have some good strategies for that. It's also really helpful that we as adults model emotion regulation for our children, right? So sometimes we can have the tendency to think, well, I need to present myself as together all the time and always handling things. But actually, it's more helpful for our kids to see that we experience negative emotions sometimes because we're all humans. And how do we deal with that, right? So maybe if I had a really stressful day at work, I say, you know what? I'm feeling really frustrated about my day today and pretty stressed out about tomorrow. So what I'm going to do is I'm going to drive to work early so I can have kind of 10 minutes in the car ahead of time to listen to my book and just get in a good mindset before I go into work, right? We will get to negative behaviors. It's our last bucket of strategies, right? So here we are. So consequences are really our last bucket of strategies. These are what we save for those behaviors that aren't improving with positive reinforcement and all the other strategies that we talked about. Why do we save these for last? We really don't want to bankrupt ourselves, right? I've had parents walk into my office and say, well, there's nothing left to take away. I've taken away their phone for the rest of the school year. They're grounded. Like I have nothing left, right? And so you want to be sparing with these consequences, and you also want to keep them short. Research shows that actually the length of time short punishments work better actually than longer punishments because we're more effectively able to hold them out, right? Otherwise, if they're too long, they tend to be infeasible and we give in, right? So if we're talking about minor attention-seeking behavior like whining or negotiating, right, we want to use something called planned ignoring. So you can talk to parents about shifting your attention to something else until the child flips that switch in the right direction. And then we want to flip the attention back on, right? I sometimes tell parents that this is like a broken elevator button. If you press the elevator button, it doesn't light up. What do you usually do? You keep pressing it until you figure out, oh, okay, the button's broken. I'm going to figure out something else, right? And so kids are usually going to push your buttons when you're using planned ignoring until they figure out that that's not working. So the behavior is going to get worse before it gets better. And that's actually a sign that the parent is doing the strategy correctly. We can also talk to parents about how to remove privileges. For younger children, this can look like a timeout. Those are actually pretty hard to put into place consistently. So removing privileges like screen time, for example, tends to be more feasible for a lot of families. And again, keeping them short, keeping them for those last behaviors that aren't improving with all of the other strategies. I'm going to turn it over to Dr. Jeung for our last strategy, which she loves to talk to parents about, and that is special time.
So this is one of the tools I just use a lot, is the special time or time in. And basically it's undivided parental attention, and it's consistent, and it's something that the kid can count on. And this is a way of, I think, dialing back some of the conflict and trying to change that parent-child dynamic so it's more positive, less negative. So the way it works is that you schedule a time that's regular and you label it special time. And it's one-on-one time between parent or the caregiver and the child. There are no interruptions. The parent is not doing chores at the same time or doing other errands or anything like that. It's undivided parental attention. Kid picks the activity. And the whole point is just to have fun together and enjoy this time together. It doesn't have to be super long, but if it's consistent and the caregiver and child are actually enjoying each other's company, this is money in the bank. Every time we have to scold a kid or redirect a kid, that's money out. But this kind of positive interaction is building up goodwill and just re-strengthening that attachment, which is a foundation on which all these other disciplinary strategies rest. And it tends to reestablish the kids' motivation for positive behavior. I've often found as parents start doing this, it's not a light switch, but with consistency, the temperature often goes down. It's not quite as like the panic feeling anymore in the house that this has just like gotten out of control. So this is a good one, and one that you can that I use all the time as a pediatrician in the office. Next slide, please. So this is another one that I like to use. It's the Incredible Years Parenting Pyramid. I know that the script is a little bit small, so it's a little hard to read. But what you have at the base of the pyramid are a bunch of strategies that you want to use more often. And as you go up, you want to keep using those strategies a little bit less and a little bit less until you go way up at the top and you have consequences there. And they're an important part of the toolkit, but you want to be doing relatively less of that than playing with the kid, paying attention to the kid, like talking and just, again, enjoying each other's company. On the small script to the right, these are some of the benefits for the child. And so I love this diagram because it summarizes a lot of effective parent management training principles in one place. And it gives you a quick overview of a lot of the strategies that Dr. Haack has already reviewed with us. So this is a wonderful one. Now, this comes from the Incredible Years, and that's one of the many brand names of the psychosocial programs that are out there. So many of these parenting programs like Triple P, Positive Parenting, Incredible Years, Barkley Method, the Kasdan Method, or 1-2-3 Magic, they've all been studied. They all have been shown to have some good effect, especially for disruptive behaviors. There's special flavors of this for teens, that special forms of family therapy to help our high-risk teens. And there's pretty good evidence for all these, for disruptive behaviors and for ADHD. And so it's good to know what's available in your community. Many times we don't have time to review this with our families. And so it's really great to be able to refer kids and families out for this help in the community. So get to know what's there. Next slide, please. I'm handing this over to Neal.
All righty. This slide's about sort of highlighting a point that Dr. Haack illustrated earlier with the perfect kind of idea of the child continuing to push that button and then realizing the button's broken. And as pediatricians and people who work with kids and who hopefully appreciate child development, helping parents anticipate this is really, really important. Letting them know that it's really important for them to expect a child to push back harder. Okay. This is super important. The extinction burst that you see on here, it will go down, it will get better, there'll be some recovery. I'll test it back a couple times again, but if parents are ready for this, then they'll be able to actually handle it and be prepared. Next slide, please. Okay, we're going to wrap up with some child-focused treatments. We're talking about how to help parents a lot, but we want people to make sure that they know that there's treatment systems for kids out there. There's psychosocial treatments, which are first line with rewards, special time that Dr. Jeung alluded to, which is critically important to build that relationship. There are adjunctive therapies, individual psychotherapy for children. When they're younger, more play-based therapies work. When they're older, more cognitive-based therapies like CBT can work. And then when we talk about medications, I like to think of them as being second line, making sure some of the first line interventions are in place or at least have been tried and initiated before medications is a general principle of practice. Obviously, there are some times where the fire is too hot to put out because the child's biology is really getting in the way of function and safety. And so I think of sort of 4 main criteria for thinking of medications. If it's a safety problem, that child's so impulsive that they're putting themselves or others in danger. If there is a relational problem, if parents are, crying that they love their kids, but they don't like them anymore because they're having so much tension, sometimes that's where medicine can be helpful. If there's a learning problem, we're having so many challenges at school because of behavior, medication can often be helpful. And lastly, if there's a self-esteem problem. And so Medicines are a huge topic. Just briefly, different medication classes that can be helpful in this population of kids, specific to their symptoms and diagnoses. Obviously, if this ADHD is present, strongly consider a stimulant trial. It never ceases to amaze me how many times it reframes things for parents when their child's paying better attention and when they're less impulsive. For more maladaptive behaviors or aggressive behaviors and severe impulsivities, different medications can be helpful. The alpha agonists such as guanfacine and clonidine are helpful. And many general pediatricians are comfortable prescribing those. I will see patients who've already gotten good trials of those, even as a specialist. Obviously, if we go into more specific diagnoses and severe irritable behaviors, aggressive behaviors, other medications, such as atypical antipsychotics and mood stabilizers, are things that you probably want a specialist to initiate, and you'll want to support more in the background as a primary care doc. And that's it for this slide. Here's some resources that we've quoted that we will often direct families to. A lot of these can be available on audiobooks, so parents can listen to them with varying, obviously, literacy and availability levels to read. And there's a lot of good websites. All of this and more will be included in the handout.
Next slide, please. So a few more resources here that you should know about. Again, this is from the Incredible Years, their website there, Triple P Positive Parenting. Another great approach is collaborative problem-solving approach. I think this is great for especially as you get into pre-adolescent and adolescent years, as a way of reducing some parent-child conflict, to help parents avoid blaming their child for a lot of behaviors, but to recognize some of the skills limitations and the unsolved problems that are leading to problematic behaviors. So it's a great approach. There's more information there at thinkkids.org. This is a QR code if you want to go ahead and snap it. And Jessica, I don't know if you can actually, or one of our other staff, or maybe I can cut and paste this link in later, but it's also on our CAP website, what some of these resources and treatments might be that you might be able to pass on to our families. Next slide, please. Some of our references, and we can go ahead and move on. Okay, so this is our QR code to check in, so you can get credit for attending today's session. And as we are doing this, I'd like to go ahead and direct some of these questions to our group here. So maybe it's helpful to talk about the difference between positive reinforcement and negative reinforcement. I've always personally found that a little bit confusing. So Dr. Haack, would you mind just clarifying what exactly that is and how that works?
Sure. You are not the only one. I'll actually, when I teach general psychology, I show videos of popular media, like TV shows, getting this wrong. So reinforcement is anything we do after a behavior that increases its likelihood to continue, right? So if we think about how we could use this effectively for children, let's say a behavior we want them to do is to follow instructions the first time. If we give something, if we provide something like praise or rewards, that's positive reinforcement. If we take something negative or aversive away, that's negative reinforcement. So maybe I take away their screen time limit, right? And what we know is that reinforcement either positive, adding something pleasant, or taking away something aversive, that's much more effective than punishment. Because again, we're actually teaching the child what it is we want them to do. Their brain pathways are strengthening. When we do punishment, all we do is tell them what not to do. And also, we tend to not like people that punish us. We tend to not want to communicate with them, work hard for them. And it also shows them that punishment is something to do to other people, right? And so particularly physical punishment, we obviously want to discourage, but really that reinforcement should be done much, much, much more often than any type of punishment.
Okay, so for our next question here, are Neurontin, gabapentin, and or lamictal used as mood stabilizers? So I'll direct that issue your way, Dr. Rojas.
I muted again. So Neurontin and gabapentin are the same thing, I think. Lamictal and those medicines are kind of used a lot, especially in neurology. Anything from sleep disorders to restless leg syndrome to chronic pain. I don't typically prescribe them a lot. I'll have patients sent to me from neurology already on them, and sometimes we'll tweak the doses, especially around sleep. Lamictal is used for seizure disorders as well as mood disorders and requires some pretty close monitoring for pretty severe side effects. Usually psychiatry is prescribing those if it's for a mood disorder, obviously neurology if it's for a seizure disorder. Using psychotropic medicines in young children obviously is fraught with a lot of challenges. As kids get older, it's a little bit easier to monitor for side effects. So I think it's incumbent upon all of us to make sure we've got good backup with psychiatry.
Wonderful. Next question is, any behaviorists you recommend for families with difficult cases? And I'd actually love to hear from both of you. But before I turn it back over to you, I want to do a little bit of advertisement. So CAP offers a Reach Out and Connect service, which is actually a chance for caregivers to talk directly with one of our psychologists, including Dr. Haack. And so you start by actually calling the CAP line, talking with a psychiatrist consultant, and then if you decide together, that would be great. It would be helpful to have the caregiver talk directly with one of our psychologists. Then that can be arranged. And so Dr. Haack is available, and she can talk directly with some of your caregivers. And so I wanted to point that out because I think this resource is underutilized. But I'll go ahead and open this back open to you, Dr. Haack, since I've introduced you this way. Any behaviors you do recommend?
So I'm hesitant to recommend a specific person or practice, but what I always coach families to do when they're asking about evidence-based therapy is these are kind of some signs that what they're getting is good treatment. The first thing is there should be a treatment plan with goals that are tracked and monitored throughout so that everyone involved knows what's working, if it's not working, what to change up, and if it is working, when it's time to stop, right? So there should be really specific goals and progress monitoring. The second thing is that magic cannot happen in a 45-minute visit every week. Really, the main work of therapy happens outside of the session. So the parents should be given homework assignments where they're told to practice these strategies at home and then come back and discuss how it went. If those two things are happening, you can consider you're getting pretty good behavioral treatment, because that frame will allow the team together to do the right behavioral strategies to make a difference.
Okay, wonderful. Dr. Rojas, any particular resources or places that you'd like to recommend?
So just like Dr. Haack, I'm hesitant to recommend a specific place. And the reason for that is the topography of what's available, and waiting lists is changing so fast now, especially coming through the pandemic, that, I'll tell a family one day a program and, find out that program's closed the next day. There's ways to tap in and get these resources. I always tell families, obviously, to work with their insurance first. I think the Psychology Today website's useful in having a lot of people available, They're not always good fits, but at least gives you a big sense of what's out there. And using resources through schools. Schools often pair up with people who are good in the community and accessible. Parents Place, which is an organization in San Mateo County, and there are parallel organizations in San Francisco and Santa Clara County, have great programs for parents. So there's good stuff out there, but it's changing a lot. And I wholeheartedly agree with Dr. Haack's points in terms of knowing what's good and being able to stick with it, and how to know it's good by getting homework is really important.
Fantastic. Thank you so much. Next question. How do you approach parents who are separated or divorced and have different approaches to disciplinary techniques? They don't even have to be separated or divorced. So you can have parents who are very much together with very different approaches to disciplinary techniques. And let's start with you, Dr. Haack. Do you have thoughts on this?
This is a great question because, that one of the main C's is consistency, right? So we know that if we have inconsistency in a household between caregivers or even within a caregiver, our child is less likely to succeed. And so I will often start by a discussion of exactly that. And really, the more you can use motivational interviewing strategies to have the parents elicit why that's not working, you can find windows of opportunity for where they may be motivated to make some change, right? Compromising, meeting in the middle is always best. Even if they're not willing to do that, are they at least willing to or able to have time every day or every week to communicate about what's happening? So at least they're on the same page, right? That is a tough question though, and one of the more difficult things I would say about doing parent behavior management training.
That's enough to make you want to reach out for that family therapist, right? Okay, wonderful. Are there other questions? I invite people to either type them into the Q&A or type them into the chat. I want to apologize that the slide didn't get fully updated here. Clearly, our next talk is not in January on autism. Our next talk, we have a special session on the first Thursday of October. It's called Navigating the Mental Health System of Care and Finding Resources. And so that will be happening October 6th. The flyer should have gone out through the CAP listserv. You do have to register separately for that because it's kind of like an off-cycle type webinar, but it should be good. It's being led by our CAP care coordinator, as well as Shelly Nakaishi, very experienced psychiatric nurse practitioner working in the East Bay. Our main topic, like a month from today, will be anxiety, diagnosis and treatment. That'll be happening October 13th at this hour. We will have a special session in December, again, earlier in the month on motivational interviewing. So please be sure to look out for those CAP flyers that are coming through the listserv. Because special sessions are coming up and not just the ones that occur monthly at this time. I am not sure if people have additional questions. Okay, the question here, was this recorded? Patients came late. Yes, so this will be recorded. It should be going up onto the CAP website under the education tab. If you look around a little bit, this will go up there usually within about a week. The recording should be up there within the next few days. Does insurance cover parent management training? And I don't know that it necessarily does. Generally, I've seen these things either offered for free, like in community nonprofits, or like on a sliding scale in other nonprofits. But maybe Dr. Haack or Dr. Rojas know otherwise.
So it can be. For instance, at UCSF, the HELP program has parent management training groups, and it's hard to say because it does kind of depend on the insurance and the plan. But it can be. There also are some programs that are offered through Medi-Cal or Medicaid. So for example, at the San Francisco General Hospital, they run triple P parenting groups. And then as Dr. Rojas mentioned, there is an increasing effort to get this offered through the schools. And actually the Bay Area is one of the leaders of this in the country. And so that's another way that's free that in my ideal world would be available in every school. And maybe a few years down the road, we'll be able to get closer to that.
That's a great goal to reach towards. I wish this were available in every school as well. Another question. When should one expect some positive results when instituting good behavior management techniques in a 4 to 7-year-old? What can a parent expect? Like, when can we expect there might be some light at the end of the tunnel here?
So a lot of it obviously depends on the severity and the frequency of the types of behaviors. Can everybody hear me? Okay. And so I would tell parents, a couple of weeks. You gotta be trying something pretty consistently. There's that word again, for a couple of weeks before you're gonna see stuff. And a lot of that has to do with how a young child's gonna process it, and start to recognize patterns, and the quality of the interventions that's happening with the child, right? A parent can think that they're trying it and their ratio isn't 5 to 1, maybe it's 1.5 to 1 or 1 to 1, and they're not quite getting enough positive attention in there yet, or enough special time in there. And so helping parents understand what the measurable kind of things are in terms of a frequency or a severity of a behavior, or time spent doing more positive behaviors, that's a good initial thing to talk about when parents are going to go out and try some of these things, because then you'll be able to look at your note and go, oh, well, you said bedtimes were really rough, and now you mentioned the bedtimes are going a little bit smoother. There's something you can help them realize. Oh, that's how you're interacting with your child is actually positively affecting bedtime, to help give them more specifics and encouragement.
I would agree. So I have, for over a decade been researching one of these parent programs that we do run through the schools. And actually we see results surprisingly fast with many families, even just starting with the special time. A lot of times we do that on week 1. And a lot of times the parents come back to week 2 and say, I cannot believe the improvement I saw in my kid. I thought this was never going to work. And I tried it, and wow, they're really listening to me more, and we're having a more positive relationship. I would say what you have to be more mindful of is that the effects can reverse really quickly if the parents stop using the strategies, right? And so I think that's a conversation to be had, certainly, that when you stop doing the routine, when you stop doing the praise, when you stop doing the rewards, research shows those kids' behavior goes right back. So how can we make sure that we're keeping consistent, even if you see kind of an initial burst? Or how do you keep consistently trying if you're not seeing that initial burst, as Dr. Rojas was saying?
Fantastic. Thank you so much.